Right. Thanks, Christy. So we'll move on to the second one. So my name is Paul, first year resident. So let's get started. So we'll get started with the case. So we have a chief complaint of a 44-year-old male with decreased mental status. And here are the vitals, noting a temperature of 89.9. And blood pressure is low but stable, and heart rate is 70. So moving on, so what else would you want to know in this patient? I want to know some past medical, right? So he has alcohol use disorder, cirrhosis of the liver with ascites, diabetes, has a history of spontaneous bacterial peritonitis, and just recently came back from Haiti 2 days ago. And then on physical exam, he was alert oriented ×2, which is not his baseline. He appears jaundice with a distended abdomen and appears to have edema of the lower extremities bilaterally up to the thighs. And his meds include Lasix, spironolactone, and thiamine. So moving on, we drew some labs, and here are some of the preliminary labs. So we have some significant labs here of a potassium of 7.6, creatinine of 6.6, a lactate of 9, and a white count of 14. So moving on, we have the initial EKG. See here, it's normal sinus rhythm, about 75 beats per minute. There's no specific ischemic changes. And we also had a CT head, which was because of his altered mental status with no acute intracranial pathology. So a few more labs start to trickle in, and we see them here. We have a TSH of 40, a T4 free of 0.2, cortisol level 175, as well as a very elevated BNP, troponemia, and bands came back at 19. So before we even start discussing our endocrine feedback loops and CCT, we get an update from a nurse telling you these vitals. So now the blood pressure is 70/40, respiratory rate is 12, and now they're alert but not oriented and kind of mumbling. So we make our way very dramatically over to the patient and running down the halls, just love stockpile photos of doctors running. And we finally get to the room and we observe these two things. So number one, we see non-pitting edema with a waxy appearance of the legs. In addition, we didn't notice this before, but we see a surgical scar at the neck. So bringing everything together, we have kind of a focused differential diagnosis of what's going on. So we are thinking septic shock, maybe due to another SBP or meningitis, Myxedema Coma because of those thyroid levels that we saw, adrenal crisis, hypothermia of another reason or environmental, CVA, or a drug intox with a few of the drugs you can think about listed. So at that point, or during the course, we did ceftriaxone, ampicillin, and vanc pretty early, as well as acyclovir, before we, to cover meningitis. We did perform a paracentesis. 2 liters were drawn off and we sent them for analysis and culture. No LP was performed because the paracentesis analysis did show elevated WBCs and other things consistent with an SBP. And we had to keep administering multiple amps of D50 for persistent hypoglycemia. The final impression ended up being kind of septic shock secondary to SBP, triggering a Myxedema Coma or decompensated hypothyroidism, as well as acute decompensated heart failure secondary with a troponin secondary to demand ischemia and a respiratory acidosis. Which leads me into my clinical pearl, which is going to be Myxedema Coma. So myxedema is the swelling of the skin and underlying tissues that typically appears in a waxy kind of consistency in hypothyroidism, as in hyaluronic acid deposits seen in like pretibial myxedema. Though in this setting, the term is used more broadly to describe the general condition associated with hypothyroidism. But instead of using this medically esoteric word, I prefer to think of myxedema coma as decompensated hypothyroidism. So I say this because decompensated hypothyroidism better explains the physiologic decompensation as it relates to thyroid functioning. So as we know, medically stable hypothyroidism can present as fatigue, depression, cold intolerance, hoarseness, though homeostasis is met. However, significant physiological stressors can tip someone over into from well-compensated into decompensated hypothyroidism. And the push into the state can present with features where you can expect all physiologic processes to be super slowed down to a detrimental state. This would be decreased mentation, respiratory drive, and body temperature. And if you remember the case in the CCT, the patient was chronically ill with liver cirrhosis prone to abdominal infections. And this particular infection led to septic shock and tipped him over into the decompensated state. So back to our hypothalamic pituitary thyroid axis. Thank you, it was perfectly timed with Christy's lecture. So the serum levels of each of the hormones involved in the axis are crucial in the presentation and diagnosis of the patient with myxedema coma. So T4 is usually very low. This would in turn upregulate the TSH levels seen in primary hypothyroidism. The levels can be low, normal, or even slightly high in central hypothyroidism, as well as like a significant stressor is going to decrease your hypothalamus and all of its functioning. And so that would lead to a decrease in the corticosteroid or corticotrophin releasing hormone, and then downward into the adrenals, so low ACTH. You can also reveal on labs like an anemia, hyponatremia, hypoglycemia, hypercholesterolemia, and high CK. So when T4 is low, like I said, everything kind of gets slowed down. And so there's key features associated with this. So number one, altered mental status. So somnolence and lethargy can be seen for even months leading up to it and can lead to a comatose state without interventions. Number two, you have defective thermoregulation or hypothermia. And so the worse that you have hypothermia, the worse the prognosis. So get the rectal temperature in and start monitoring. Body temperature could drop sharply in the setting of cold weather, like poor Patrick Starr here. So think of poor Patrick Starr to remember that myxedema coma mostly develops during the winter months. And then finally, the precipitating event. So it's going to be present and you have to be vigilant about identifying the trigger. So look for cold exposure, signs of head trauma, heart failure, stroke, anything that could destabilize homeostasis, and then a drop in blood volume secondary to dehydration or GI bleeding or internal hemorrhaging, like you can see in ectopic pregnancy, could also decompensate homeostasis. So there's often a history of hypothyroidism or radioactive iodine treatment, and remember to assess to see if there might be a surgical scar in an altered patient who won't tell you about their medical history. So the treatment, the mainstay is going to be thyroid hormone replacement therapy. This is essential to the treatment, but options, there are options and opinions differ in about the dose and preparation, meaning T4 or T3. But what's recommended is a high dose. So a high dose of T4 or T3 carries the risk of precipitating a fatal tachyarrhythmia or an MI. However, too low of a dose may not treat it sufficiently. So it's recommended to start with T4 at an initial dose of 200 to 400 micrograms IV, followed by daily doses of like 50 to 100. Keep in mind that the treatment with T4 may not be sufficiently effective due to impaired conversion from T4 into T3, which is seen in severe illness or inadequate caloric intake. So after a day, it's recommended to start T3 at a dose of like 5 to 20. So this will be done in the ICU. And IV administration of thyroid hormones is replaced by oral administration when the patient is fully awake. So as we discussed before, the pituitary adrenal function could be impaired. So you can give IV hydrocortisone every 8 hours at about 100 milligrams IV to help with that. And then finally, like a vigorous search of the precipitating event is imperative, but it's recommended to start empiric antibiotics as early as possible in the event that you're to cover for a septic shock. Myxedema coma is an emergency, endocrine emergency, and aggressive treatment is super important because there's a high mortality rate of 30 to 50%. So you also have like other supportive measures, including like there's gonna be hypoventilation, so don't delay intubation. Hypothermia, so warming blankets without any active peripheral warming. You can do central, just not peripheral, because that could lead to vasodilatation. Hyponatremia and hypovolemia, so cautious resuscitation. So normally you can do normal saline, but if there's hyponatremic encephalopathy, you can consider then 3% normal saline. And then treat the precipitating event, obviously, and then also giving D50 because there's probably going to be lots of hypoglycemia as well. So, staying vigilant and doing frequent point of care checks. So back to CCT, we did give Synthroid 400 milligrams as well as hydrocortisone. Essential line was placed, desmopressin and levofed were started, and eventually blood cultures did grow Staph galolyticus and Candida. And unfortunately, the patient did die in the MICU, only emphasizing the high mortality rate. And going back to the senior lecture, this is kind of another exacerbation. I feel like this has been done before with the patient, and this was kind of the last trigger that then led to his demise. So key points, myxedema coma, think about it as decompensated hypothyroidism. Make a priority of identifying the trigger and treating it. And that would include starting prompt empiric antibiotics, and this is associated with a high mortality. So being very aggressive and staying on top of the patient can kind of help. Here are all my references, and thank you to the clinical pro staff, same people, for helping me out at the last minute. Any questions?
Very nice.
It's so hard, it's so easy to miss myxedema coma because we're going to see thyroid storm so much more than the myxedema, and the myxedema is going to kind of sneak in every once in a while. And these patients are going to appear like septic shock, and you're going to be like, oh, this is just a septic shock patient. And so if you don't think about it, you're not going to get that IV levothyroxine started, and you might be a little behind the 8 ball, which will make you feel really bad. Because I still feel bad about the one that took me a couple hours to diagnose. And it's been probably like 8 years, and I still think about it.
In this case, the bradycardia, usually sepsis, you have tachycardia. So let me ask a question. Was he non-compliant with because of the thyroidectomy, obvious thyroidectomy?
So he was compliant. We don't know why. I mean, my theory is, like we even talked about this, we were discussing even if this is myxedema coma or not, because he's just so severely sick and there's so much going on that was it just kind of physiologic response to that, or was it full-blown myxedema coma? At the end of the day, we did treat, and the patient, was so severely sick that he ended up dying. But, we actually also added on the TSH, the same thing. Like we didn't initially do it, and then we went back and added on and found it. So
patients present like sepsis.
Yeah.
The giveaways are first of all the heart rate and also the hypothermia. Yeah, you can get hypothermia and sepsis. It's just less. It happens less. We talk about it maybe a lot more, but I think the giveaway here is that there probably was an element of myxedema coma is the hypothermia,
right.
And that glucose that was kind of on the borderline. Yeah, hypoglycemia also kind of goes along with it. So, but that's why it looks so much like sepsis, because hypothermia, hypoglycemia, hyponatremia, that can all kind of happen in the dehydrated septic patient. And that's why it's so easy. I think this patient had myxedema.
Yeah, so supposedly he was adherent. It's just maybe when he was on vacation or went down to Haiti, he didn't have it. Who knows? Yeah.
Maybe it was just the SBP.
The SBP, absolutely. Yeah. Any other questions?
Very interesting.